Thank you all for being here. Of course, I'll be watching you on the Restream and over at the Rumble Rants. Today, it's Dr. Michael Turner and, of course, Dr. Kelly Victory here with me as well. Dr. Turner is a board-certified physician, graduate of Stanford and Harvard. I believe his medical school training was at Harvard. Physical medicine, rehabilitation doctor, as well as regenerative medicine. He, Stanford undergraduate, Harvard Medical School, that is correct, and residency at the Mayo Clinic. So he is well-trained. He dared to use a little improvisational medicine when he was approaching some patients. And for that, his license is being challenged by his state medical board, and he is suing along with three other physicians who are in a similar situation. We're going to talk about that with Dr. Turner. You can follow him on his website, michaelturnermd.com. Substack is drturner_substack.com. And Instagram is Dr. Michael Turner, MD. Let's get to it.
Our laws, as it pertains to substances, are draconian and bizarre. The psychopaths start this way. He was an alcoholic because of social media and pornography, PTSD, love addiction, fentanyl and heroin. Ridiculous. I'm a doctor, for Christ's sake. Where the hell do you think I learned that? I'm just saying, you go to treatment before you kill people. I am a clinician. I observe things about these chemicals. Let's just deal with what's real. We used to get these calls on Loveline all the time. Educate adolescents and to prevent and to treat. If you have trouble you can't stop and you want to help stop it, I can help. I got a lot to say. I got a lot more to say.
I think everyone knows the next medical crisis could be just around the corner, whether it comes in the form of another pandemic or something much more routine like a tick bite. You and your family need to be prepared. That's where the Wellness Company comes in. You know the Wellness Company. We have their physicians on like Dr. McCullough frequently. The Wellness Company and their doctors are medical professionals you can trust. And their new medical emergency kits are the gold standard when it comes to keeping you safe and healthy.
It's a safety net. It's an insurance policy
absolutely.
That you hope you're not going to
100%.
need, but if you need it, you sure as heck are going to wish you had it if you need it.
Be ready for anything. This medical emergency kit contains an assortment of life-saving medications, including Ivermectin, Z-Pak. The medical emergency kit provides a guidebook to aid in the safe use of all these life-saving medications. From anthrax to tick bites to COVID-19, the Wellness Company's medical emergency kit is exactly what you need to have on hand to be prepared. Rest assured, knowing that you have emergency antibiotics, antivirals, and antiparasitics on hand to help you and your family stay safe from whatever life throws at you next. Go to drdrew.com/TWC. That is DRDREW.com/TWC to get 10% off today. Just click on that link. Welcome, everyone. As I said, we'll have Dr. Kelly Victory in here in just mere moments. And for now, we are introducing Dr. Michael Turner, who's going to
It's when I was on call, I'd pull out, my vitamin C, my ashwagandha, my ginkgo, whatever, take my supplements, right? I was a guy, when I was on call in the hospital, I was doing yoga in the break room, doing some up dog, down dog, side plank, whatever, just stretching. And I never felt like I had to be limited by what I was learning in those institutions, as august and venerable and fantastic as they are. I never felt like I was limited to that. I felt like my job was ethically to respond to the patient with whatever the best stream of information would be. If it means you need to get an MRI, then that's great. If it means you need to put blueberries in your smoothie because they're good for cognition, then that's great, right? If it means you need to take ginkgo biloba because it improves cerebral blood flow, if it means you're overdue for a colonoscopy for colon cancer screening, whatever it is, my job was to pull the best piece of information and provide it to the patient. So I had that mindset as I went through. I was tremendously well trained on all the traditional sides of medicine, but unfortunately, a lot of the more naturalistic or holistic aspects were self-taught, self-motivated, continuing education courses and such. But as I then finished up at the Mayo Clinic,
I want to stop you if you don't mind.
Yeah.
Right there. So your postgraduate training was in physical and rehabilitation medicine, correct? Is that accurate?
Yes.
At Mayo?
Yes, exactly.
Okay.
Yes.
And so were you doing the traditional path then of stroke patients and post-hips and, post-acute hospitalization stuff, or was there something else going on?
Yes, traditional. So I got recruited by a hospital here in Washington State to work in an outpatient neuroscience center. So I was doing a lot of neuroscience rehab, also mixing in a bit of orthopedic rehab with that. But I had my interest in integrative medicine and wellness all along. And that actually, we could talk about it, but turned out to force me into a career change because I just felt boxed in essentially at the hospital.
And then you am I correct that you have another board certification in integrative medicine? Is that true? To the extent that
No,
there is
no.
such a thing?
Yeah,
No.
there are some
Is there
accrediting
such a thing?
organizations.
Yeah.
I don't know
Go
if
ahead.
it's yeah, I don't know to what level it's risen in terms of being an official
Okay.
subspecialty or something like that. But there are certain certification programs.
Okay.
No, I'm not board certified in integrative medicine, but I use that title because the title of integrative medicine because it most aptly describes what I do essentially.
Okay. And would it be accurate to say that, the I don't know how to frame this in a way that's accurate, that the evidence basis for a lot of the recommendations in integrative medicine these days has risen to a standard of evidence-based practices? Would it be accurate to have said it that way? That
Oh,
this is not 1980s like when Kelly and I were training, when there was almost it was the Wild West. But now there's a lot of, when I, for instance, when I talk about a supplement, and the first thing I ask for is, get me the data, and there's usually a whole stream of good studies that they can provide for me. So is it accurate to say that the evidence basis for your recommendations is up to a reasonable standard of quality now?
certainly. I pride myself on that. I try to be evidence-based in everything that I do, and because that's my integrity and that's also the patient's time and energy and money and health risk, right? I don't want to be chasing every bandwagon or some MLM scheme or something I read about on the internet. I have to recommend it in a good conscience. But what's interesting? A lot of things that used to be considered alternative medicine are now very mainstream. For example,
That's right.
vitamin D, right? Vitamin D is a great example. Is vitamin D alternative medicine? It's gotten more and more mainstream. The literature's off the charts in terms of what it does to the immune system, musculoskeletal health, etc. And so now it's almost mainstream. Your primary care should check a vitamin D level just like he or she should check a cholesterol, right? Another example.
True. I do that. I'm a primary care guy, and I do that all the time now. And there's even some other sort of interesting data on vitamin D sprinkled throughout. For instance, it's one of the only things that is shown to do if I state this accurately as I can, decrease the risk of progressive metastasis in outside the capsule disease of prostate cancer. Which is kind of interesting.
Wow. Yeah.
Yeah.
I know.
Yeah.
I know it has striking
So-
anti-cancer properties. Absolutely.
Yeah. So, all right. So you're in regenerative medicine. How long have you been in that field?
Basically since 2009, I was working at the hospital, but doing a lot of integrative medicine sort of within that job, right? So patients would come to me for their back pain or their post-surgical rehab, but then they would also have complaints like, I don't have enough energy, or I want to lose weight, or I wonder what my thyroid's doing. So me trying to pull together integrative solutions goes back to the beginning of my career in 2009, but really jumped off in 2020 when I went into business for myself.
Okay. And then COVID hits. And what did you think of that whole experience? Forget what the fallout was for you. As it hit, what were the kinds of thoughts you had as we walked into this extraordinary circumstance?
Yeah, well, first of all, bewilderment, desperation.
I had all those. Yeah, sounds about right.
Right? Desperation,
Yeah.
strong drive to figure out an answer, right? I had patients calling me, I don't want to get this. I heard it's pretty bad. I got grandma or somebody in the hospital. How do I prevent this? Which was my first question. Is there a way to prevent it? And then came the early treatment questions. I'm coughing. My SATs aren't great. I don't want to go to the ER. What do I do? Or somebody went to the hospital, got remdesivir and didn't come out. I don't want to be that person. What do I do? And sometimes people coughing and being quite acutely ill on the other side of the telemedicine visit. So it was like my time to rise to the occasion. I felt like, now is the time for all good men to come to the aid of their country, kind of a concept. So it was our time as healthcare providers. This is what we're trained to do. We need to step up.
Well, I think, you're in good company here with myself and Dr. Victory. We sort of had the similar kind of feeling, like what is going on? Now you got to stand up and ask questions. It's kind of a scary circumstance, but like I said, I don't know if you got to see that there's a little stream we play ahead of the show. I was in this particular, when I was interviewing Megyn Kelly, and I said, I felt like I was part of the French underground. We were talking, we were sending out information that was forbidden just to ask questions about what is going on here. And so you ended up getting into the early treatment world, I guess, or offering early treatment. One of the cases went bad, and you have now a situation with the medical board. Tell me about that.
Sure. Well, I got into early treatment through utilization of the FLCCC protocols, which were game changing for me, saved a lot of patients' lives. Most assuredly, people come back and tell me that. Kept a lot of people out of the hospital. And, things were going swimmingly. And then some anonymous complaints would have started to be filed, which is interesting. You mentioned a case gone bad. A case never really went bad. I'm under investigation for a few things, but not any of them relate to a case going bad. The case that went bad, quote unquote, in the eyes of the medical commission is a gentleman who had very severe COVID. I did everything I could to help him, including ivermectin, including other appropriate forms of medical care. He unfortunately died of COVID several days later in the hospital. And they tried to pin my use of ivermectin as being causal in some of the pathophysiology that led to his death. I would more aptly say that he just died of severe COVID. And unfortunately, I couldn't help him with what I did, right? That's the most sort of egregious, or aggressive concept that the state has. Other than that, it's simply people, basically they're prosecuting me for violating their COVID misinformation statement, which your producer may be able to pull up for us, but they passed this statement similar to what they did in California, which you're very familiar. You may want to talk to that point. They passed the same thing in Washington, right? Here it is, COVID misinformation statement. And right in there, it says, physicians who generate and spread, quote unquote, COVID-19 misinformation or disinformation erode the public trust in the medical profession and endanger patients. Okay, well, fair enough. That sounds all good, but let's go figure out, how do you define that, right? And they go down a little bit farther, and here's kind of the kicker. It says the WMC, which stands for Washington Medical Commission, relies on the U.S. Food and Drug Administration approval of medications to treat COVID-19 to be, quote, the standard of care. Interesting.
Wow, I guess we can't use the vaccine then. We can't use the vaccine then, can we?
Isn't that funny? Because you know what else was not approved by the FDA? The vaccine. Why wasn't that on here?
Yeah.
In fact, Dr. Drew, thank you for mentioning it. I'm going to put on my
In fact, hang on a second, Michael. You're not able to use aspirin or Tylenol ever, because those aren't FDA-approved treatments of anything, ever.
Good point. I've got a COVID test kit right here. Binax now. All right. I bought this thing from CVS the other day. Drew, you're going to get a kick out of this. Here's what it says. This product has not been FDA cleared or approved, but has been authorized by the FDA under an emergency use authorization.
EUA.
So this thing is not FDA approved either. This should be on their misinformation statement. Why are we allowing people to take this terrible stuff? It's not FDA approved.
Since when does the FDA, this is the thing I can't get people to understand. I was doing a nightly newscast here locally, trying to help people make sense of COVID and stuff. And the anchor, who's a great guy, and we had a great relationship, and he started going, well, what about what the FDA is telling you to do? And I go, the FDA can't tell me anything. The FDA has nothing to do with the practice of medicine, literally nothing, except it tells companies that are bringing medical products to market how they can market them. That's it. That is other than that, I can do anything that is in the best interest of the patient. And if you want to talk about misinformation, I mean, Dr. Walensky talked about stopping the spread of COVID. And then she went, oh, no, we can't stop the spread of COVID. Well, which was the misinformation? Back and forth. Misinformation is one of the most egregious terms. Had you ever heard of misinformation before 2020 in the practice of medicine? In 40 years I practiced, not a word that we talked about disagreements, we talked about alternative opinions, we talked about alternative practices, but we did not talk about misinformation. The idea that science has misinformation, no, I reject that completely. Galileo was presenting misinformation in the eyes of the Spanish Inquisition and the Pope. That was misinformation. So, where do we stop, everybody? Who decides what you can and can't talk about with your patients? This is insanity. I hope you have good lawyers that can scream about it the way I'm screaming about it.
Thank you, Drew. I appreciate the passion. I do. I've got some great lawyers. I agree. Here's what's interesting. How can you have immediately a standard of care, first of all, by the FDA, which has got nothing to do with anything, because as you said, they don't have the mandate nor the authority nor the expertise to determine whether a particular patient should get a particular medication at a particular point in time.
Nothing.
That's called medical decision
and by the
making.
way,
That's why you.
By the way, if they ever do claim that privilege, well, now we can sue the shit out of them when they make mistakes. So good on them for getting into this practice with us. It's hard work. Enjoy it. So go ahead, keep going.
Sure, no problem. But apart from that, let's say you had organization of doctors XYZ that said this is a standard of care and what you're doing is outside of that. It's misinformation. I have to ask a question, right? Critical thinking. How can you have a standard of care so quickly in the midst of a novel and evolving pandemic that the world has never seen?
I agree.
I mean, come on.
And by the way, yeah, I agree. And by the way, if people, I've always felt like professional societies could get involved with this, right? I mean, your physical rehabilitation, I'm sure you're part of some professional society with that. If they want to ask questions, they're entitled to ask questions. I think that's a reasonable, but those organizations don't seem to have gotten involved with any of this because they know how challenging this all is. Go ahead, finish your thoughts, and we're going to bring Dr. Victory in here. Go ahead.
Sure. Yeah, appreciate it. Well, my other thought was to say that ivermectin is not FDA approved to treat COVID is really to say nothing. It's an absurd statement on many levels, right? Because let's just ask the question: how could it have been even FDA approved, right? I mean, the FDA approval process takes time, it takes money, it takes years. So here we are into a novel pandemic. Who has studied ivermectin for years that has gone through the full FDA regulatory process to get FDA approval, and who would be willing to bankroll it since it's a generic medication, right? I mean, of course it wasn't FDA approved. It's a kind of a nonsensical statement. The question is, does it work?
Yeah.
And was it plausibly helpful to keep your patients from going to the hospital and dying? It's kind of funny. I use example. Let's say there was a raging wildfire sweeping through your community, right? And you got in your car and you punched it, and your car was up to 100 miles an hour and it was getting near the red zone, right? This would be like saying, oh, the National Highway Safety Administration has not approved your car to drive at 100 miles an hour for more than 5 minutes at a time.
Right. That's right.
And you're like,
that's right. Yep.
Okay, but it might, and I need to go for it right now. And I don't have time for these people to rule on something that they don't have the situational awareness to talk to me about anyway.
No, you're right. And listen, I was saying that if nothing else, I'm sure, once you prescribe to somebody sick, you follow up carefully. And one of the things that was not happening during COVID was people were told just, take an O2 finger monitor, go home, come back when it's 87. That is not medicine. I don't know what that is, as opposed to, I'm going to give you something, Tylenol, and then let's talk in 24 hours and 48 hours and see how things are going. I don't know. Maybe it's that when we prescribe, we follow more carefully, I think, perhaps, or we're involved in the treatment of the patient at that point, and it changes our follow-up practices a little bit. We were doing the opposite of that during COVID. So I wonder sometimes if just the act of, being engaged with the patient therapeutically was enough to monitor them more carefully and keep people out of trouble just by itself. I mean, I'm prepared to say that. But anyway, let's stop right there. I want to bring Dr. Victory in. I've used up all my time by myself with you here. Let's see. Is there any place you want to send people how about michaelturnermd.com if you want more information? And the Substack is drturner_subscat.com. We're going to take a little break. We're going to do some business, and we'll bring Dr. Kelly Victory in here. Susan and I have been looking for nutrition-packed, great-tasting greens drink for a while. And then we tried our friends at Paleo Valley's organic super greens, which is superior to what's out there on the market. Our friends at Paleo Valley, well, they think of everything, and they've created what's been called a magical green powerhouse. All three delicious varieties, pure unflavored, strawberry lemonade, and tropical, contain 23 certified organic, antioxidant-rich superfoods, including the highest quality spirulina. It's also free of cereal grasses, gluten, grains, soy, and dairy, and no added sugars or artificial sweeteners. And what's more, it delivers digestive enzymes, polyphenols, which are believed to burn fat, and 8 essential amino acids. Imagine the time, effort, and cost of trying to make this yourself. It's impossible. Head on over to drdrew.com/paleovalley, and you will get 15% off your first order. All the great products they have there, 15% off. at drdrew.com/paleo, Paleo. Fall is right around the corner, which means dry, flaky red skin from allergy season is coming with it. But the best way to take care of your skin is with our skincare secret, Genucel. You don't need to worry about that puffy, tired eye look or those annoying dark spots or even dry, flaky skin because Genucel Skincare has you covered. Susan and I love our Genucel products so much, we want you to try our personally curated skincare bundles. It's risk-free at Genucel.com/Drew. Genucel works so well, you can see the results in this unplanned live moment on our show when the Redness Repair Cream repaired my skin in just minutes right before your eyes. Their concentrated vitamin C serum helps keep your skin plump and hydrated. Plus, with their immediate effects, you can see astonishing results in under 12 hours. Quick, effective, and easy. Go to Genucel.com/Drew right now to try our bundles and save over 60% today. And remember to enroll in Genucel's world-class concierge program for additional savings and free shipping. Don't wait. It's Genucel.com/Drew, GENUCEL.com/DREW. These products have transformed my life and Susan's and saved our marriage. Discover the key to oral hygiene, regardless of your current daily dental routine. Whether you diligently brush and floss multiple times a day, or you struggle, you got bleeding gums, bad breath, plaque buildup, this revelation is for both of you. Surprisingly, over 350,000 Americans experience health issues that may be connected to their toothbrush or even caused by it, ranging from heart or blood sugar problems, forgetfulness, digestive difficulties, immune issues, all related to oral hygiene. Scientific studies have shown that a simple switch of your toothbrush can lead to a healthier teeth and potentially save your marriage. Yes, save your marriage. Our study, we did a personal study. My wife, Susan, hates the sound of the sonic toothbrushes, but introducing the Real White Sonic toothbrush, of course, also their hydroxyapatite dirty mouth mineral toothpaste by Primal Life Organics, these products have transformed my life and Susan's and saved our marriage. It's much quieter. It's a very powerful toothbrush, but it is quiet and it saved our marriage. So, the Real White Sonic toothbrush from Primal Life Organics stands out among all other electric toothbrushes I've tried. It effectively eliminates plaque, harmful bacteria, promotes gum health. Get yours and enjoy 60% off at naturaltoothbrush.com/DREW. Some platforms have banned the discussion of controversial topics. If this episode ends here, the rest of the show is available at drdrew.tv.
There's nothing in medicine that doesn't boil down to a risk-benefit calculation. It is the mandate of public health to consider the impact of any particular mitigation scheme on the entire population. This is uncharted territory, Drew.
Dr. Victory, I've had my fun with Dr. Turner. Now I turn him to you.
Michael, great to see you. I'm so glad to get in here with my hair on fire. You guys got your hair on fire really early on. I got to, get in here too. Normally we wait a little later in the show until we get quite so fired up. I want to give a little bit of backstory here. Dr. Turner and I met Drew at a recent conference up in Spokane, Washington, where we were both speaking to a group of people at a medical freedom conference. And before, it's a group of physicians, nurses, nurse practitioners, physical therapists, pharmacists, all of whom have decided to really get out of the system because of the perverse incentives of the system and the algorithmic thinking and the pressures to behave in a certain way. I think that this COVID debacle, frankly, has fueled what was sort of an underground movement for a while. And I think that what we've seen in the last 3 years has added tremendous energy to this movement where people are saying, see, this is why I want out. And I really want to spend some time getting into the weeds with you, Michael, with regard to treatment and the use of what they are calling sort of repurposed drugs and get into that. But before I do, I really want you to take a few minutes and go back, because there's a part of your story that I don't think we fully expose to our audience, which is the egregious nature to which you were persecuted, and you were. And many of us, by the way, it was sort of an informal competition at that conference in Spokane. People saying how many complaints they'd had filed against them, and how many. I've had 7, and Mary Talley Bowden had 5, and other people have had. We were comparing how many people have been attacked. But you had a story that I found particularly heinous with regard to what the board did in terms of trying to fundamentally assist people in filing complaints against you. So just talk a little bit more about what happened and then what you did, where you ended up going and working, what you've been doing, where you've been practicing.
Yeah, sure. Well, thank you, Kelly. I think it dates back greatly to a TV article or a TV report that was done. So one day I was in clinic and my secretary said, "Hey, there's a reporter here who wants to talk to you." She left, but here's her business card. This was a Friday afternoon. I had a busy clinic the rest of the day. So I figured I'll call this person back on Monday and I'll get my side of the story, whatever the story is. I don't even know what it's going to be, right? That night I'm at the gym and my phone is just blowing up. It's ringing off the hook. And I was working as an independent contractor, leasing a space in a larger clinic. And this was the owner of the larger clinic. He's like, "Your name's all over the paper. Our clinic name's all over the news, rather. What's going on? What's this deal? Are you prescribing ivermectin?" I'm like, "I don't know what you're talking about. I am prescribing ivermectin, but news story, I have no idea what you're talking about. I mean, a reporter dropped her card off. I don't know. Is that what you're talking about?" He's like, "Go check the news out," right? So I went on the news and they aired this pre-packaged hit piece, is the only way to characterize it, about ivermectin, saying, "Oh, poison control calls are up and it's veterinary medicine and it's horse paste." And they literally had cutaways to horses in stalls, and then cutaways to very concerned looking news anchors, and then cut away to a Washington State public health official saying, "By no means should any human being be getting ivermectin. That's a ridiculous, concept." And then Dr. Turner couldn't be reached for comment. And then, by the way, if you want to file a complaint and you think there's been a violation of the standard of care, here's where you do it. And they published the phone number. And this also was in their print piece. And so it was kind of a very unfair, in my mind, characterization and a takedown piece with this blatant, invitation to click this link and call this number to file a complaint. Well, not surprisingly, I had a number of complaints roll in over the next 6 months. But here's what was curious. None of the complaints were actually from people I treated. None. Nobody said, "Oh, Dr. Turner treated me. He didn't do a good job. He was hasty. He didn't talk to me. He didn't follow up." Nobody said that. Right. Nobody's close family even said that he didn't take good care. The complaints would come from like an ER doctor who had an incoming patient and they noticed that they were prescribed ivermectin, and they did a little sleuthing and found out that Turner prescribed ivermectin. And then they pulled up the Washington State misinformation statement, which we just read, and said, "Voila, I'm going to report him." Right? Or it'd be from somebody's distant relative, like an aunt who was a nurse, and the nurse thought that, her relative should not be subjected to the hands of somebody so irresponsible and ridiculous as to give them ivermectin or hydroxychloroquine. I must report him. Those were the contexts of the reports, honestly.
And that is 100% consistent, by the way, with my own experience. Not one of my complaints was from a patient, not one. It all had to do with things that I said on air, or things that I said on radio or television or wrote in op-ed pieces in the newspaper. Not one was a patient complaint, and they all were done anonymously. Same thing with Mary Talley Bowden and all of the other physicians and clinicians who I spoke to at that conference who had complaints against them. These were not complaints to the medical board in the way we normally expect, where a patient is saying, "I went to see Dr. Turner or Dr. Victory, and this is how I was mistreated, and I think the board needs to investigate." So I think people really need to understand that physicians are being attacked, but we are being set up with these hit pieces in a way that has never happened before in the history of medicine. I've got a couple decades on you, and I can tell you it has never happened before, Dr. Turner. Now, make a segue, if you would, to talk briefly about then where you went after that. How did that you were renting space or leasing space in a larger clinic? What was their response, and where did you go?
Well, interesting. So the owner of the clinic was quite irate, exercised, would be a fair word. I had to talk him down a little bit. We had a meeting of the minds. Interestingly enough, I was still open to the vaccine at that time, and I was pro-vaccine, and I had actually been vaccinated. And that kind of helped smooth the waters a little bit. He's like, well, you're not anti-vax, are you? I'm like, no, I just got the Pfizer, last month. So that bought me a little bit of room in his mind that I wasn't a wackadoo that needed to be, disassociated from immediately, thankfully. And so he actually took out a position that I respect very much. He prepped his staff. They came out and they made a public statement that said, Dr. Turner's an independent contractor, rents space in our clinic. He's free to treat patients as he sees fit. We don't see that he's done anything wrong. And so I stayed there for another year, actually, entirely. So that ended up working out all right. But to your point about the investigations, what's interesting too is they would say, okay, they would subpoena all these documents essentially and say, send me all the records for this patient. I'd send them all in. Then I would not hear anything from them. Months would go by, no response. And then I'd get another one. Oh, there's been a complaint about patient so-and-so. Send us all the information. Again, no response. These things would stack up. They would give you no response. And then when they did respond, it's like tentacles. They would keep asking for other things that weren't really even relevant. And so at one point, my lawyer's like, we're not giving you any more documents. We're going to have our day in court. Like, let's adjudicate this matter. But you beating us over the head endlessly with requests for documents is not a game that we're going to play anymore. And I thank him for having the chutzpah to do that,
Yeah, I think another thing I want to interject here, and I hope it's not lost on our audience, is when I sit here talking to you, you're Stanford trained, Harvard trained. For me, I'm Duke trained. Went to Oxford. For Drew, it's Amherst and USC. Not exactly. We didn't exactly go to Make-A-Wish programs. On the back of a matchbook cover. Truly, I mean, you look at the people who we have on this show, whether it's Peter McCullough or Jay Bhattacharya from Stanford. People from Oxford, Harvard, Yale, Stanford, Princeton. These are some of the most preeminent universities in the country. We are all, to a person, extraordinarily well-trained, highly educated, well-trained. We are not a bunch of wackadoos. We are all doing what I and you, and I know from my extensive conversations with you, Michael, have what we were trained to do, which is critical thinking, to actually do decision making, to be capable of inductive and deductive reasoning, and to apply what we've learned clinically and apply it to the individual patient. Somewhere along the line, and this is what I'm most interested in right now, somewhere along the line, we went astray, and that has fallen by the wayside, not just in medicine, by the way. Critical thinking is absent, is AWOL in a lot of parts of our society, but certainly very obvious in medicine. Talk a little bit about that piece, and I'd like to hear your thoughts about that and hear what your experience was with your coworkers, colleagues, with regard to what you were choosing to do, thinking, I don't even think outside the box. I just think thinking, critically.
Yeah, good point. Glad to do so. Well, the critical thinking is so necessary. We must preserve that role as somebody who's independent and has the patient's best interests in mind and their sole interests in mind. Right. And I'm very motivated by a quote from William Mayo, one of the co-founders of the Mayo Clinic. And he said, the best interests of the patient are the only interests to be considered. Right. And that's part of what made Mayo Clinic great. And I respect them very much. And I had a great education there. And I carried that forward. But what that means now is you also have to get your critical thinking cap on, right? The best interests of the patient are the only interests to be considered, not the political pronouncements of the FDA, not the political position of some current administration, not what the Washington state governor says. What's in the best interest of the patient? And the problem is that the doctor or the healthcare practitioner is typically operating at the underside of a big, large structure, this massive pyramid, right? That's very conflicted, that has heavy ties into pharma and insurance and the federal government, because federal government through Medicare is the biggest insurer. You know this. We could talk about these kind of things, but essentially, we've lost the voice and the space to be the unbiased guardian of the patient's best interests. We are at our worst now just seen as slavishly obedient or enactors of larger policy interests that many times collide with the patient. And that's where we have to stand up and take our stand, but we can't many times in these structures. It's a big, big problem. We've got to get unconflicted there, Kelly. We've got to break away, or we lose what's at the heart of healthcare. This is vital. This is way bigger than ivermectin. This is way bigger than COVID. This is about, when I go see my doctor, can I trust him or her to think about me and me only and me first? Or are they thinking about prosecution from their state political commission of God knows what, or FDA?
I could not agree more strongly with Michael. I really think we need to come up with systems of delivery outside of the traditional systems, like some other models that physicians who can use their brain still and are willing to do so and are properly trained to do so can represent the patient exactly as Dr. Turner is suggesting. Kelly?
Well, Drew, that's exactly what this conference was about, because I would submit to you, you work for whoever pays you. That's a fact. And 80% of physicians are employees of large hospital systems, large medical groups, or insurance companies. You work for who pays you, which means if you are employed by a large hospital system or a physician group or an insurance company, you are not working for the patient. You may say that you are, but you're not. You're working for United Healthcare or Anthem or Aetna or Kaiser, whoever's telling you what you're going to do. And the electronic medical record is part and parcel with this. The electronic medical record is not actually a medical record. It's a billing template that incidentally captures a few pieces of clinical data. That's all it is. Okay, I'm sorry, but that is a fact. And the drop-down boxes that tell you what you're going to order and what the order set's going to be and what prescription you're going to give. And this is a perfect segue, because this is why we have started to call these things, quote, repurposed medicines, because the system would like you to use the newfangled medications that make somebody a lot of money. And it's only if there's nothing else in the expensive bundle of new toys that you can use, that then they will allow you, okay, you can use the one that only costs 2 cents a pill that we've known about for 50 years. Oh, okay. Because they'd rather have you use the other one. I remember I grew up in a big family, big Catholic family. And when we'd wrap presents for Christmas, my mom always wanted us to use the little scraps of stuff that was left over, but it was way more fun to pull out a brand new roll of wrapping paper and use that, because that's the easier stuff and it's prettier and no one's used it before and it's really fun.
Shinier.
No one wants to use the little scraps that are left over, but those are very valuable. And I'll tell you, in the medical system, this whole thing is corrupt. And so they want you to believe that these other things don't work, like ivermectin or hydroxychloroquine or vitamin D.
Yeah. But Kelly, there's a kind of a pernicious element in here that I'd love to see you two talk about, which is a large number of our peers feel entitled to centralize the decision making. I'm thinking of a friend of mine that was doing some very creative work with pain management, and he was very nearly lost his job. And now the protocols he was advocating have become entire West Coast wide systems protocols, because they finally, after years of vilifying this guy and God knows how many patients being improperly served, they went, oh, you have a point now. I think of the opioid crisis. The opioid thing was exactly the precursor to all of this. What do we do with our peers who feel a value, who feel not just entitled, but it's valuable to centralize in these huge bureaucratic systems that I think the three of us believe is anathema to proper care? I mean, this is a worldview issue, right? Their worldview is, I remember I gave a lecture in Bermuda and I was talking about the over-centralization and how that resulted in so much of the problems with COVID. And I could feel the audience going, like, I could feel their muscles tightening up, like, oh, you're against us. We're for these big systems. And I thought, really? How is that? So help me walk through that. How do we get people back to the basic principles of what Mayo represented and Sir William Osler represented, and the three of us were trained to represent?
I'll throw that to Mike. Dr. Turner, you take a bite at that.
Well, I think it's crucial for us as individual practitioners to reclaim our vision for who we wanted to be and why we went into healthcare in the first place. This is a lot of where it starts, right? Like we start, I think, with great motives. We want to be a change agent in the lives of patients. We want them to trust us. We want to work in their best interest. and we have this grand vision of who we can be and, the kinds of effects that we can make. So are you living that out? Do you feel that in your current structure and system, you have the freedom, the intellectual freedom, the pragmatic freedom to bring that to bear and to make it happen? If you don't, and you're feeling a little conflicted, then there needs to be a change, right? Like, it's not enough to just say, well, I've got great benefits and a matching 401k from my hospital, and I just don't want to make too much noise. It's like you're violating your conscience and you're not being your best self as a healthcare provider. So I think if we roll back
Okay,
and
I'm gonna interrupt. So you're saying stand up for what's right, which I totally agree with. But what do we do with our peers who believe that what they're doing is right to centralize it the way they have?
Well, I guess one thing would be point out the flaws of that, point out where it doesn't work out well. It's the conflict between the collective and the individual, right? Which is a socio-political concept. But we have the Bill of Rights and the Constitution and the idea that the individual has certain inalienable rights. So that extends to the medical realm as well. It can't just be collective good and we ramrod certain medical guidelines down people, that we can point out the breakdowns of that philosophically, historically, even.
Yeah, I think, Michael, you just hit the nail. The core of of my talk about the lack of critical thinking was this pernicious sort of shift from the individual to the collective. Everything fundamentally, things like informed consent, Drew, are anathema when you're talking. Informed consent is based on the individual patient. If you now are saying that your individual rights or your individual best interest is supplanted by the what's best for society, what's best for the community, what's best for the collective. This focus all of a sudden on the collective. And that's what happened with public health, that we have conflated. Public health and individual health are very different. I know the difference because I am both. But when I have my individual practitioner hat on, my focus is exactly as Michael said, that individual patient and that individual patient alone, nothing else. When I put my public health hat on, it's very different. I'm now looking at the entire, at the collective. We have conflated the two, and I would submit to you, there's really very little individual healthcare anymore. In individual healthcare, the fundamental construct of autonomy, there is no such thing, in individual healthcare as taking one for the team. The idea of you should take a vaccine, Drew, and be subjected to potential risks because it's better for your neighbors. Sorry, that's not how it works. It's supposed to be.
I think to hear you guys talk, I think we are going to have to come up with. We're going to have to outcompete. We're going to have to get like-minded people together that are interested in the individual patient and medical freedom and outcompete. That we might end up with two parallel systems even. But we have to go out there and compete, literally. I think that's, Dr. Turner is young enough that I can still call on him to really go out there and do it. I'm not sure I'm up for it anymore. But I think we have to do that. We have an obligation to do that.
So talk about that, Michael. What you have a lot to say on that topic. I heard an interview with you and Dr. Kat Lindley, who is a friend and a friend of the show, with Del Bigtree, talking specifically about that. So how do you think that we create that parallel system or retake over the individual system?
Sure. So I think on the practitioner side, it's breaking away from insurance. That's the first step. Because as you said, you work for whoever pays you. Insurance dictates a bunch of things. In fact, if you're a physician, you're not happy with insurance. It's not a great setup, right? They're in your business. They're killing you with paperwork. They're mucking around. You don't like them. You want to fire them. You're just afraid to because your bottom line, you don't know what might happen to your bottom line, right? So we've got to create some systems that then welcome doctors and say, you know what? You're free of insurance. Come on over here. Let's lose these people. Let's lose United and all these other groups, and let's make decisions in the best interest of the patient. Wouldn't actually be hard. Tons of healthcare providers would flock because you know what? Tons of healthcare providers are leaving the profession anyway, just from pure burnout and dissatisfaction, right? So we can offer them a better alternative. But on the patient side as well, I think it's very compelling. Again, you want to, if you were going to a financial advisor, you'd want him to be unbiased and looking at your portfolio, making your best interest, right? You wouldn't want to hear about all these backroom conflicts that he's getting paid and kickbacks and all this stuff. You pay for someone to manage your money expertly and you trust in it. Same concept. Patients will want that. They'll pay for it all day, left, right, and center. Most of my patients still have primary cares who they see through their insurance, but that's sort of like a second level concept to them. They're not greatly attached to that. They're like, yeah, I see my primary care every 6 months or so, because Medicare makes me, and they don't usually have time. They don't answer a lot of questions, whatever. And then I come to you and I pay you cash, and I enjoy our conversations because you spend time and you care and you listen and you learn. And you know what? I'll do that. So they'll pay money because the value is there. And so it's compelling on both sides of the equation. We just have to create that system and welcome everybody in, which is being done.
And to be fair, it's not, we're really talking about, think about it, just to not to get into the weeds too deeply, but we're really talking about an outpatient system. The inpatient system, which is, potentially financially catastrophic, that can be still covered by insurance.
Right.
Insurance
Absolutely.
is insurance against catastrophe, insurance against excess financial burden. And then the actual people that are responsible to keep people out of the hospital can operate completely independently of that.
Yeah, when I was growing up, that's what we called major medical. We paid our pediatrician or our internist cash. We paid. We're fundamentally self-insured. But then my father carried what we called major medical in case you fell off the roof or you had a car accident or you got cancer or whatever. You got covered for that catastrophic event. But otherwise, you paid for your routine care. And I think that's. I was shocked, Michael, to tell you the truth, at the number of people and the amount of energy at that conference, that there are that many people. And a few, by the way, Drew, real success stories of people who are primary care folks who are doing it the good old fashioned way. I mean, they have one other person, generally a front office person, not even a nurse. We had doctors saying, I know how to take a blood pressure. I know how to ask the patient to stand on the scale.
That's what I do,
I know how to
Kelly.
draw
That's
a tube of blood.
what I've done for years.
Yeah.
That's what I have done for years. That's how I've done it.
Yeah.
And it's hard to make ends meet and stuff, but I because I take Medicare and insurance. And one of the reasons, by the way, one thing you guys left out as to why we listen to the insurance and take the insurance is I don't want the patient to incur a bunch of expense because the insurance all of a sudden says they won't cover something that was necessary. That can get awful. I don't think people understand how inexpensive primary care can be. It can be very inexpensive. It's not a costly process.
Right.
No.
How do you manage yours, Michael?
So I'm cash. I'm cash based. It works out well for people. To give you an example, though, the gentleman who spoke at our conference, Kelly, Dr. Edgerly out of Yakima, Washington, you can look him up. He has a so-called direct primary care, which is cash-based membership. Right. It starts at $100 a month and goes down from there with discounts for families. And his guarantee is, I will see you on the same day. If you are sick, you can come and I will see you in person. And then, by the way, he does ultrasounds and x-rays and EKGs at cost, has a lot of generic medications at cost. Yakima, Washington is not a populously thriving, economically vibrant upper class area by any means. His practice is busting at the seams, expanding all the time because the value there is tremendous. How many people can't even get a call back from their primary care? They can't even get a return phone call or an email or a call back. And then the next visit out is months and months, if anything, right? And then when they get in there, they're rushed. We can do better than that. And you can do better than that for $100 a month. I mean, some people spend more than that at Starbucks.
Yep.
Right.
Agreed.
No, and I said you have to be careful. People need to be careful not to conflate the idea of concierge medicine with this direct primary care. What you're talking about, Michael, is direct primary care, which is back to the way it used to be, where you've got a physician who takes only cash. And I paid an arm and a leg to sign up for this, quote, concierge program, which gets me supposedly, preferred appointment times and longer appointment times and things like that. And I'm saying what I want is a doctor who's capable of non-algorithmic thinking. Somebody who doesn't give blind deference to authority, somebody who actually thinks out of the box and is willing to listen to my particular concerns and do what's best for me. And that's the kind of model you're talking about.
Sometimes that's concierge medicine. I don't want to disparage those are people also trying to manage this mess. You know what I mean? I admire them trying to do it. It's just another model.
But if you're still taking insurance, I would submit to you, if you're primarily an insurance-based model, As I said,
Yeah.
I will maintain you work for who pays you. And if you're being paid by the insurance company, that's who's, you're dancing to their drum. And I
Yes.
think that's a problem.
Yeah, and to reiterate your point, Kelly, it's a great point. From the patient side, what you've done when you go see your insurance doctor, when you get insurance, you've essentially outsourced your medical care to the insurance
Right.
company.
Mm-hmm.
Right.
Yep.
You've outsourced it to them. You say, I pay you and you figure out my insurance, my medical care. And they say, fine, these doctors you can see and these you can't see. And this procedure we'll pay for and this we won't. Right. So by the time you go see your doctor, you think it's just you and the doctor in the room. It's not. The insurance company's sitting right there in the middle of you like the 500-pound gorilla that nobody wants to talk about. And you've subcontracted your care to them. By the way, do you think they have your best interest in mind? Do they have financial conflicts of interest? Do they have massive lobbying conflicts of interest? Right? I mean, why does it make sense that you would want to subcontract your care to them? And the problem, the illusion that a lot of patients are under is when they're sitting in there with the doctor, they don't realize all this and they think that the doctor's just speaking from the heart, truly saying what's in their best interest. The doctor's going, I know that this is what insurance will pay for. If I go this other route, I'm going to have to do 58 pieces of paperwork and I don't have time for that. Right. And I got to sign and fill out all these like Medicare ABN forms and a bunch of stuff you and I know. Right. Or I might get sanctioned by the hospital because it's off protocol for what they want. So I'm just going to take this easy route because I got to move on to the next patient. Right. So they're not giving what they know truly in their heart many times is in your best interest, but you'd never know that.
You're right. It's even more insidious than that because the recommendations that get codified into, what your average internist thinks is the quote, what do the recommendations say for mammogram? Well, the recommendations for mammograms used to be every year after age 40. Okay. That was it. You get a mammogram every year after. All of a sudden, a few years ago, it changed to every other year after age 50 and nothing after age 70. Well, was that based on some new scientific study? No, that was based on an actuarial study, a financial study run by the insurance companies who said, yes, X number of women will die, but it's worth it because we will save this many bazillions of dollars by not doing other mammograms. That then becomes the quote recommendation. So now Dr. Smith, you go see Dr. Smith and Dr. Smith says, no, Kelly, you don't need a mammogram. It's every other year. You don't need one this year. Well, based on what? Based on not what's best for me in my medical care, it's what the insurance company decided. So the big issue is that the recommendations that you then believe that you as a patient believe are based on science is most of them aren't based on science. Most of them are based on financial drivers.
Yep. Listen, you guys don't have the experience of being in the psychiatric setting, which I did for 30 years, and the egregious excesses of what I mean, I could tell you stories about how insurances ran the show in a psychiatric hospital that was routinely killed people. And their position was, well, we don't practice medicine. Look, there's Dr. Pinsky or Dr. Smith's, his signature right there on the discharge form. We didn't make him discharge the patient. Of course they made them. There was no more resources available, even though the doctor is saying this guy's going to kill himself. He needs another week in the hospital. They're like, no, sorry. And that happened more. And by the way, when I would make complaints then to the insurance commissioner, the insurance company would go, oh, Dr. Pinsky, you seem to have concerns about our business practices. I'll tell you what, we'll decertify you. In fact, we'll decertify the entire hospital. That's the game they play.
Right. No,
Despicable.
it's real. Yes, it is. Yeah. Tell me, you came to this, obviously, most recently you've gone through this experience, Michael, with regard to the attacks against you and sort of coming to this. You said you have a long history. You really grew up with sort of the holistic or naturopathic side of you. What's your experience? What was it during your training with regard to your colleagues? Did your colleagues have sort of the same inkling that you did, that things weren't necessarily, as transparent as they should be? Or are you the only one?
No, yeah. I was swimming against the grain, right? I was swimming upstream. Yeah, with my naturalistic focus, we'd be on rounds. I'll never forget. Let's say we're on internal medicine rounds. There's a patient with C. diff, right? And you talk about these heavy drugs that you might give the patient. C. diff is colitis, toxic bacterial infection, right? And you're like, oh, well, we could give them vancomycin, this and that. And I'm like, what about probiotics? I'm pretty sure probiotics would be some good, right? But you get looked at like you have three eyes if you talk about probiotics,
Right.
on rounds. It's just like, oh, here's the vancomycin dosing regimen, this and that. So I learned to keep my mouth
And
shut on some of these things.
And
Yeah.
didn't stool transfer come from regenerative medicine too? I mean, that became the standard of care.
So later on, right. So later on, the idea of probiotics, Saccharomyces boulardii, for example, I actually heard that on rounds from one of the progressive attendings towards the end. He's like, yeah, we're going to give this patient some Saccharomyces. This has some help to recolonize their colon, and then stool transplant. So that started to come in a bit. Yes. But I was kind of swimming against this current, in many cases on this stuff. And it hits the medical field later, as I said, like vitamin D being an example. It kind of is slow to sweep through there. But, not only is it the question of realizing in medicine, everything we're learning is not the entire truth, and it's not even the entire best way to take care of a patient. There's a whole world of alternative things out there that are actually very helpful and very evidence-based. We're just not being told it. That's one thing, and that's true. But apart from that, we didn't realize the extent of the influence to which our minds were shaped by the whole idea of evidence-based medicine, shaking down from the journals, and the influence of pharma and all of that. And I just want to make this point and then open it up for dialogue, especially with you, Dr. Drew and Dr. Kelly, to speak further on this. But if you think about it, let's think about it from the side of the pharmaceutical company for a second. Okay, they've got a real problem. The pharmaceutical companies have a real problem because, first of all, they spend tens of millions of dollars and many, many years of R&D to come up with this product, but they can't bring the product to market until they first pass a major regulatory hurdle called the FDA. They've got to present their data. The FDA's got to clear it. Okay, so this is their first hurdle. You can do a bunch of product development and it can die because it doesn't pass FDA clearance. Now, once you get through this onerous regulatory agency, guess what? You don't have any physical means of getting the product to your customer. Right. You don't. That's called the pharmacy. So now you have a whole nother layer of people you'd have to depend on to try to get your product in the hands of the customer. Guess what? You don't have a sales team that can interact directly with the customer, right? The customer, aka the patient, has to go find some third party, aka the doctor, to perhaps write a prescription for your product. So you don't even have a sales force that can directly reach out and touch the customer. And besides all that, their fourth existential problem is your product is so overpriced that most patients can't afford it. Therefore, they have to rely on financing that you have no control over, aka the insurance company, right? So
you're leaving a part out. You're leaving one part out, which is that because of patent laws, the moment they take the drug off the shelf and identify it, the clock begins ticking, and they have, 15 years now to make their profit back, and it takes an average of $1.2 billion to get through the FDA, and 5 to 7 years, and so now you have 8 years to make your profit. That's it. And so this is another part of your story, how we fund phase 3 trials. This is Harvey Risch's thing, and how we construct them and how we do them. Maybe big data is going to solve some of these problems, but how, who is funding the phase 3 trial? Only pharma has enough money to do that, and only things that are going to give them profits at the other end. So regenerative things don't get on the radar at all.
No, and unless we disarticulate big pharma from all of this, that's what I was you've come full circle to exactly where I wanted to be. Some of the things that you refer to as alternative, medicine, things like vitamin D or ivermectin, really aren't alternative at all. If you actually look at the studies that have been done on them, if you were actually able to find the studies, we have known, apparently somebody has known for decades that vitamin D fundamentally was the strongest anti-cancer agent we have, not just for prostate cancer, Drew, but for all kinds of cancers. It is the item. It is the thing that the pharmaceutical companies don't want you to know about because nobody can make money off of vitamin D. So I would submit to you that it's not that these things are alternative, it's that the information has been actively suppressed, because you really have to, how do you get to it? It's not showing up in the journals. They're not talking about ivermectin. It wasn't until I had a dog, literally a Labrador retriever, that had breast cancer that I found out that ivermectin has been known to be highly effective against breast cancer for decades. Decades.
Yep.
Okay. There are
Yep.
studies on it. You mean, Dr. Turner, you've seen them. You and I have swapped them back and forth. These aren't new studies. This is stuff that the NIH has known for decades, that the FDA has known for decades, the CDC has known for decades. They have actively suppressed it. And this has to do with, really, talk about agency capture. How do we get the pharmaceutical companies the heck out of the practice of medicine?
Right. I don't know exactly how we begin to do that. We're gonna have to have some smarter minds on it than mine. But to illustrate that point, a company's gonna do what a company's gonna do, right? And they exist to make a profit and to stay alive, and it's a dog eat dog world, right? So they've got those 4 barriers existentially to even getting their product into the hands of the customer, and maybe a 5th one, as Drew was mentioning. So what are they going to do? They're going to exert all possible means to control that process at every step of the way. They're going to exert all possible means to control and influence the FDA and the pharmacists and the providers who write the scripts and the insurance companies and anybody else who stands in their way. They've got to, right? It's like if you were Ford Motor Company, but you couldn't have your own showroom, nor sales force, nor in-house financing. You got to depend on other groups. Well, to stay alive, you're going to figure out how to influence and control those other groups. And that was my point. I never realized quite how much I was controlled in my education by hearing and understanding just what pharma had dictated through the journals, et cetera, because I was being shaped essentially to be that direct-to-consumer salesperson for pharma, right? Unspoken in some senses, in some cases more overt, but that's what it is. We're the ultimate sales force that has to touch the consumer directly. They depend on us. So they figure out how to influence us. You can bet they do. And we need to make other healthcare providers aware of that and get them to be breaking free.
No, I agree with you. And I think that, Drew and I have talked about this in taken a lot of different approaches to this. The capture of what I call our storied medical journals. I always prided myself in being, that physician who actually went to the Lancet and went to JAMA and went to the BMJ and read the article, read the study. And now I feel sort of like an idiot because it turns out what I was reading was fundamentally, propaganda. Much of it was really the vast majority of it funded by pharmaceutical companies. It's hard to find that out. It's really hard sometimes to understand the conflicts of interest. They're not readily apparent. Even when you read the conflicts at the end, sometimes there's so many layers. It's hard to actually know who funded the study, for example. And so somehow we have got to retake rebuild the integrity of the scientific process within medicine, because as long as it's funded largely by a big corporation, i.e. big pharma, you can't trust. I mean, I don't know who it was who said, I think it was Joseph Fryman, who said, when I buy a Samsung television, I don't read the reviews that are written by Samsung. I try to read, it's that kind of, but that's what it is. When you read an article
a little bit, but I want to push back a little bit and say that I don't want to vilify pharmaceutical companies. As by the same token as they do whatever they have to do. I know. It's okay. I'm not going to vilify you for doing so either. But it's I have had the benefit of many medications, and I've used both personally as a patient and for my family and my patients, that there's been remarkable advances that pharmaceuticals have brought us and that I've been able to use. And after all, as someone who's not using a scalpel all day, all I have is physiology and pharmacology I have a couple other things I can do too, but I'm trying to adjust very powerful biology sometimes. And sometimes things have gotten away from us, and we have very, very, very sick people in front of us. And there's some good studies out there that I think we have to have a jaundiced eye when we look at these studies. I also am pushed back on the idea that pharmacy actively suppress this thing. I think the editorial process is where things have gone off the rail. And so we're just not seeing the full range of data that we should be seeing, both positive and negative on pharmaceuticals and on non-pharmaceutical interventions and, readily available molecules that don't make anybody money. The editorial process, I think, is where things have gone way, way sideways. Because, as you and I know, Kelly, we've seen studies they were excellent, took 2 years to come to a journal, and the majors turned them down. And there's something wrong there. Everything goes just in one direction. And yeah, that's a problem. We have to undo that, whether it's using RICO laws or like RFK Jr. says, or just exerting the pressure as a community. We have to get that improved. But it's remarkable that things are as good as they are, I guess is what I'm saying, given all these outside forces that can potentially adulterate things.
Dr. Turner, thoughts on that? Because
I could see where Drew's coming from with that. Pharmaceutical companies aren't entirely evil. I'm not trying to say that. I'm thankful for certain meds. I prescribe certain meds at a time. Obviously, Ivermectin is a medication, was developed and brought to market by a pharmaceutical company. So I'm thankful for that. We have to realize the limitations, and we have to be able to have an honest dialogue more than anything. I'll use the vaccines as an example, right? Why can't we just have an honest dialogue about the pros and the cons of this new medical technology, right? If this were some new cardiac stent that came out on the market and a couple years in, we found serious death signals and had cause for concern, we should be able to have an honest dialogue about the pros and cons and allow for informed consent. And if these things are terrible, let them be pulled from the market. But as soon as we try to discuss that as regards the vaccine, it's verboten and somehow we're silenced, right? So that's unacceptable. Anything that pharma wants to bring needs to be subject to the light of day and scientific scrutiny, just like anything else. And there needs to be some independent funding mechanisms, right, for all so-called alternative treatments so that they can develop an evidence base that's as robust. Again, some ivermectin, right, certain things are not studied because they lack a sugar daddy, essentially. They don't have someone to bankroll them through this process. Correct. Right. So where's our public health money that's funding that stuff that's truly in the people's interest?
Right. And so where I would push back on what you said, Drew, is that when you say, the problem isn't the pharmaceutical companies, it's the editorial process. Well, the pharmaceutical companies control the editorial process.
Yes.
Just like they control
I get
mainstream
it. I get
media.
That.
When you're Fox News,
I get it.
80% of your advertising revenue comes from pharmaceutical companies, you are going to promote what they tell you to. It's the same thing with the Lancet or the BMJ or any JAMA. They are owned by the pharmaceutical companies. So if if Pfizer says don't publish that study, Lancet's not going to publish that study. Or they say, do publish this one. I mean, I hate to tell you, but that's how it works. So I'm simply suggesting that we need an independence or something that is not owned by big pharma, that is not owned, by somebody who has a vested financial interest. And I have said many times that if somebody died and made me queen, I would make every article that appeared, any study that appeared, that before the title of the article, they should say who pays for this. Who is, who actually funded this study? That should be disclosed upfront so that it's very, very easy, in my mind, for the reader to understand who funded this study and therefore help you to understand what the conflicts might be. Because right now it's
I absolutely agree. I agree with that. Yep, I agree with that. I just want people to understand that the world gets into this all good, all bad kind of thinking. It's like it's the excesses. It's the things that have gone too far that we're talking about. We're not saying dismantle everything. We're saying we got to come up with alternative practices, alternative competing systems, alternative ways of doing this. because things have gone too far in a certain direction where it has adulterated the system, I think.
No,
Well, you
and
guys,
I write a lot of
Dr. Turner,
I write a lot of prescriptions, by the way. I don't, I'm not just
of course,
suggesting
of
eye
course.
of newt and wing of bat. I actually write a lot of prescriptions.
That's my point. It's all we have. We don't use a scalpel, the three of us. We use chemicals to shift physiology. And some of it has a natural, well, you get to work in the ER. We're not working in that setting so much.
I have a question.
But what's Kelly? Caleb, yeah.
Caleb.
Yeah, so I'm not advocating for this, but I think that the natural next question that some people might have is, what if we take all money out of health entirely with some sort of a universal healthcare system? How does that solve or not solve this problem with money being so involved in our health?
I will say one thing with that is how do you think let's put it this way: go to building and safety or the DMV, and you want those people running your healthcare system. That's what you're going to have, and they're going to be tightening it down and restricting access. It's going to be a catastrophe. Now, if you want to have that as one system within other systems, I have no problem with that. In fact, I think that's a good idea. But if everybody goes into it, you're going to rue the day. You're going to hate it.
I would say something similar, which is what happens then, Caleb, with universal healthcare is twice as much money actually gets spent, but all of it becomes administrative and very little of it trickles down to the people. Very little of it gets spent actually on health care. It's all administrative, becomes very bureaucratic, and the implementation of it and the bureaucracy, government's involvement in anything has never made something more efficient or cheaper. I guess it's in the history of the world.
Your best unit, Caleb, your best unit is the patient and the physician, or the practitioner and the patient. You put anything on top of that, you create inefficiency immediately. Anything. Every single thing you add to that relationship, you're making it less efficient. So we're talking about getting it back to the patients and the practitioners and letting them sort of operate as individual units. And you can do it for so much less. It's just so ridiculous.
I guess
people don't understand that.
It's probably similar to how, like, whenever I was in the hospital, one Tylenol there suddenly cost $10 because of all the bureaucracy and the red tape.
That's the insurance companies.
Exactly.
That's the insurance companies.
The prices will cost way more.
Yes, way more. All right, we're down against the clock here. Dr. Turner, any last thoughts here? We have whirlwinded you. We've ping-ponged back and forth. What else would you like to get in there?
I've greatly enjoyed the conversation. Thank you both very much for having me. It was engaging. And I always want to end on a note of optimism and positivity, because I think that's warranted. Actually, there's an awakening going on. There's a lot of momentum, grassroots. It cuts across political spectrum. It cuts across left coast, West Coast, East Coast. It doesn't matter. These are people and providers waking up to some really fundamental, basic questions. I want to be able to trust my healthcare provider. I want autonomy over what goes in my body. I want true informed consent. I want access to the best treatments. I don't want other layers interfering with me getting good healthcare. So let's keep moving together. Let's lock arms. Let's have a reformation of our healthcare system and leave this thing looking better in 10 years than it is today. We've all got kids and grandkids, and we're all going to get old and need this system at one point as well. So let's keep working hard to make it better. I'm all for it.
Amen.
Yep.
Amen. And God bless you. I truly appreciate your courage, your leadership on this. I really do. I know you've been under the gun, and I think what you're doing is tremendous. You've got a little more time to be doing this than Drew and I do. So, but I am all in. I think you're 100% right. Let's lock arms and let's fix this thing, because I think we can. And I'm with you. So God bless.
I agree.
Indeed.
Thank you, Dr. Turner. Hope we'll talk soon.
All right. Thank you so
Kelly,
much.
for you and I, you got it. We have Carrie Lake coming in here tomorrow. Next week is Baby Week. There are no shows
right, Baby Nation.
that week. Baby Nation, there she is. Then on the first, second, and third, we were going to do some caller shows. Kelly, you're certainly welcome to join me on those. I think that'd be fun, actually. Is that okay with you, Caleb, if she joins me on the Wednesday?
Oh, yeah, absolutely. Yeah.
Terrific.
And,
terrific.
Up there, but I'm...
To remind
that okay
everybody,
with you, Big Daddy?
Oh, gee. I'm about to be a father of two. It's actually starting to sink in now that I have 7 days left. It's finally there.
Yeah. It's a calm before the storm.
Yeah.
Enjoy it.
That's right.
Yeah. Well, we also have a
It's going to be a
toddler,
one-on-one defense. That's all right. You go to one-on-one now.
Right.
Well, I just
No, that's exactly
how about
right.
from 0 to 3 like I did?
Oh.
Just think about that.
Yeah.
we were always in his zone, and we were always out.
Then you got to go to the zone
you won't
defense.
sleep much.
Oh, I can
No, we
never talk
got
about
out
our
of zone.
pregnancy because you guys already went through triplets all at once. I just want
I
to
know.
remind
Sorry, I have empathy though. I do. I do.
Oh, thank you. Yeah, I know you guys have made this much easier than it's as easy as you could. I just want to remind the viewers also that those 3 caller shows, the first one on November 1st, it's all about COVID and medical freedom topics. Then on November 2nd, it's going to be anything but COVID. So all the questions that people haven't been able to ask, they can come in and ask it on that show. Then on November 3rd, it's callers on any topic, anything you want to talk about. We're just filling that week with caller shows.
So we're off the
Terrific.
30th too, right? Or
Hang
I
on
thought
a second,
I
guys.
tried to get
Yes,
that
we're off.
30th.
I'm
We're
looking at those dates. That seems a little off to me in terms of the dates.
The 30th
Let's try
is
to
a Monday.
get a Monday showing. We'll
Yeah.
talk
30th
later.
is
We'll
Monday.
talk
Yeah.
later.
Definitely the 1st and 2nd for sure. We are doing that for sure.
The 3rd's
Sorry.
fine too.
Here's our traditional.
We're flying Friday.
Rearrange
so
the calendar
We're
at
good.
the end of the
Don't do it
show.
now, Drew. We gotta tape an ad, so I gotta go.
Okay. All right. We'll keep posted. We'll keep you all
All right.
posted. And Kelly,
Bye.
thanks so much. See you next week. Okay.
All right.
Oh,
Bye.
no, the week after next.
Ta-ta.
Take care.
Bye.
For Ask Dr. Drew is produced by Caleb Nation and Susan Pinsky. As a reminder, the discussions here are not a substitute for medical care, diagnosis, or treatment. This show is intended for educational and informational purposes only. I am a licensed physician, but I am not a replacement for your personal doctor, and I am not practicing medicine here. Always remember that our understanding of medicine and science is constantly evolving. Though my opinion is based on the information that is available to me today, some of the contents of this show could be outdated in the future. Be sure to check with trusted resources in case any of the information has been updated since this was published. If you or someone you know is in immediate danger, don't call me, call 911. If you're feeling hopeless or suicidal, call the National Suicide Prevention Lifeline at 800-273-8255. You can find more of my recommended organizations and helpful resources at drdrew.com/help. Did I describe my reaction, my lightweight reaction to you guys on this show?
Yeah, is that when you smoked and
Yes.
then you had like a panic attack, right?
It was not a panic attack. I had what's called an anticholinergic delirium. I actually had no anxiety at all, because I was very cool about it, given how miserable I was.
So wait,
And I had no high. I was just miserable. I took 2 hits with some of the cool kids, and I looked like you.
That's rough, bro.
And I kid you not.
The greater the financial interests in a given field, the less likely the research findings are to be true.
The world that the greedy want to create. All of natural resources in their hands. All of land in their hands. The same billionaires who are telling the farmers, forget the land, take money and leave it, want that land. The same people who say, oh, food is unnecessary, we're going to make lab food, are the very people who are then also investing in land to have real food.
So many of these different government agencies and how they are involved with our life and where they have gone off the rail by involving themselves with these corrupting influences.
This merger of state and corporate power, where the companies that are in industries that are being regulated are capturing the agencies that are supposed to regulate them and turning them into predatory organisms against the American people.